You're watching a protected PCI.com video.
I'm very honored to present Dr. Rajan Patel, and he's going to continue this theme about what we're doing and why we want to be more complete in revascularizing in these high-risk patients.
Thanks, Bill. So in the next few minutes, I'm going to talk about some compelling data demonstrating the value of complete revascularization and give you some provocative data suggesting that complete revascularization in a single setting may be better than staging complete revasc. So I'll start with a case. This is a 71-year-old gentleman who works as a doorman at a club in the French Quarter in New Orleans, Louisiana. Those of you who have been to New Orleans for various conferences have probably stumbled upon this club late at night. It's one of those places where you know you should probably go back to your hotel after a long day, but then make the poor choice of going into one of these clubs and absolutely regret it the next morning. So he's at BMI of 48. He has multiple CAD risk factors, including a long history of smoking, as shown on the slide here. And because he has to walk several blocks from where he parks to his club, he started noticing angina, chest pain, on trying to get to work. He went to see his internist who got an echo. His EF was 25%. Sent him to a cardiologist who ordered a PET stress test that demonstrated multivessel ischemia with some transient ischemic dilatation. So he was referred for an angiogram. You can see he's got a distal left main stenosis involving the osteal LAD and osteal circ, as well as a calcified LAD with multiple areas of stenosis. And if you notice at the bottom of the slide, he's got collaterals to the PDA. And this LAO caudal view just gives you an idea of his BMI. And there, of course, is the CTO on the right. So why might complete revascularization be beneficial, especially in a patient like this, with a functional assessment that shows multivessel ischemia? So it results in less early recurrent ischemia and subsequent procedures. I'm going to show you some data for that very shortly. It provides better tolerance of events in other ischemic distribution and other coronary distributions. Provides preservation of LV function, and I'm actually going to show you some data that suggests it provides improvement of LV function in a patient like this, and results in a reduced rate of myocardial infarction and sudden cardiac death. So here's some now famous nuclear cardiology data. On the x-axis, you can see increasing amounts of ischemia on SPECT stress testing. The y-axis is cardiac death rate, so a hard endpoint. And if you look to the far right of the slide, you can see that those patients with the most ischemia on nuclear stress testing clearly benefit from revascularization compared to medical therapy alone. Revascularization in blue, medical therapy in red, in terms of cardiac death rate. So as an interventional cardiology community, how well do we do complete revascularization? Well, here's some data from the New York State Registry, as well as 3 trials that randomized patients or compared patients with PCI to CABG. The New York State Registry is real-world data. So you can see here that incomplete revascularization in the real world in the state of New York occurs as much as 70% of the time. And in these 3 trials, ARTS-1, ARTS-2, and Syntax, which compared, again, PCI to CABG, the patients, the procedures, and the operators were heavily scrutinized. And even with people with Big Brother watching us, we at best do a 40 to 50% job of incomplete revascularization. So does incomplete revascularization matter? So going back to that Syntax trial, which randomized patients to PCI and CABG, in the PCI group, here's cardiac death rate. In blue are patients who had complete revascularization. In red, patients who had incomplete revascularization. There's an absolute mortality difference there. Here are more data from the Mayo Clinic PCI registry. These are patients who either had bare metal stents or drug-eluting stents. This is survival on the y-axis, time on the x-axis. The top red line, patients with the best survival, are non-diabetics who had complete revascularization. The dotted red line are non-diabetics with incomplete revascularization. The solid blue line are diabetics with complete revasc. And the dotted blue line, the patients who had the worst survival, are diabetics with incomplete revascularization. So what about just the DES population? Here are data from the Seoul National University DES registry. A smaller population, so the y-axis is cardiac death and MI, a combined endpoint. But nonetheless, you can see there's a clear benefit with complete revascularization compared to incomplete revasc. Even more data, a meta-analysis of 3 trials that compared PCI with CABG, Syntax, pre-combat, and BEST. And in the PCI cohort, you can see there was a reduction in MACE with complete revascularization in blue compared to incomplete revasc. Even larger meta-analysis, 35 studies, 90,000 patients. And if you look at the bottom of this forest plot, which looks at mortality, complete revascularization provides a mortality benefit compared to incomplete revascularization. And if you look to your left on this slide, you can see there's a benefit in MI and urgent revascularization also. An even larger meta-analysis, 150,000 patients, slightly lower quality data, but a very large population. And look at the bottom of this forest plot. This is death. So complete revascularization seems to provide a survival benefit in this meta-analysis. So here's an interesting study from Bangalore, Dr. Bangalore. It's looked at the New York State PCI registry with second-generation drug-eluting stents and compared that with patients in the New York State CABG registry. There was no difference in death between the two patient populations, those who received CABG in red, those who received PCI in blue. However, among those patients who had incomplete revascularization, there was a clear benefit for CABG compared to PCI, and there was a clear benefit, almost a twofold benefit in terms of repeat revascularization among those who received CABG in red compared to those who received PCI in blue. However, if you look at those patients who received complete revascularization, no difference in MI event rate, and PCI starts to catch up with CABG in terms of repeat revascularization. So there seems to be a clear advantage of complete revascularization. And if PCI is ever going to win against CABG, it looks like we have to start doing more complete revascularization. So the gold standard for CABG for the last several decades has been on-pump CABG. Dr. Popma mentioned the Excel trial just now. It's a trial that randomized patients with left main disease to bypass surgery or PCI. But if we just look at the CABG population in the Excel trial, you'll notice that the on-pump group for CABG had more vessels revascularized. Everybody in the trial had their LAD revascularized, but the on-pump group had more circumflex and RCA revascularization. So the on-pump group had more complete revascularization compared to the off-pump group. And if you turn your attention to the right of this slide, this is death rate on the y-axis. And there's a survival advantage for on-pump CABG compared to off-pump CABG that seems to be related to the completeness of revascularization. Here are data, PCI data, from the Roma Verona registry in Italy. These are patients who had complex coronary disease and underwent multivessel PCI with Impella placement. This is survival, hard endpoint on the y-axis. And you can see that those patients who had the most complete revascularization, based on the BSIS Jeopardy score, which is another indicator of completeness of revascularization, those patients who had the most complete revascularization had a survival advantage compared to those patients who had various degrees of incomplete revascularization. So I've shown you data demonstrating that complete revascularization is beneficial. You decide you're going to do complete revascularization. Should we do it in a single setting, or is it okay to stage it? Well, here's some interesting data. We all see end-STEMI patients in the cath lab every day. Here are data from the BSIS registry, 20,000 patients with end-STEMI. Half the patients received single-stage complete revascularization. The other half of the patients were propensity matched against those single-stage patients and had only culprit revascularization. This is all-cause mortality on the y-axis. And you can see there's a clear survival benefit from single-stage revascularization in this registry data. We've talked about the syntax score. So in the PCI arm of the syntax trial, most patients received complete revascularization, but some had staged revascularization. And unlike in the US, where we stage our revascularization typically 30 days after the index procedure, in syntax, which was a European trial, the stage revascularization was performed between 3 days and 2 weeks after the index procedure. And you can see in red here, those patients who had staged revascularization had a high incidence of all-cause death, a high incidence of urgent revascularization, a high incidence of stroke, and a higher incidence of MACE. The happiest trial in interventional cardiology is the SMILE trial. Over 500 end-STEMI patients randomized to complete revascularization in a single setting or multi-stage revascularization. Patients were randomized 1-to-1. Here are the outcome from that trial. So MACE on the y-axis is clearly better with one-step complete revascularization compared to staged revascularization, and this was driven by target vessel revascularization. So there's the data for single-step complete revascularization. But obviously, clinical practice is more complicated than that. There are patient-specific issues that need to be addressed and operator cath team issues. Patient-specific issues include hemodynamic stability. If you're blowing up balloons in multiple arteries, there's a fairly reasonable chance that you're going to cause some degree of hemodynamic embarrassment to the patient. Well, the obvious solution to that problem is Impella, mechanical circulatory support. What about acute kidney injury? We know from a large volume of data now that if we induce AKI, we increase the patient's mortality even if they survive their index hospital procedure. So you have to be able to do multivessel PCI using low contrast. You saw some data earlier from Michael Flaherty, published 2 years ago in Circulation Research in the University of Louisville population. Using Impella during multivessel PCI seems to decrease the incidence of acute kidney injury. And he published another paper in CCI this year from the CVAD registry data demonstrating that Impella use decreases AKI incidence. You have to be able to do multivessel PCI with reduced radiation. You can't burn your patient while doing multivessel PCI. And you have to be cognizant of procedural time. It doesn't make sense to spend 5 hours in the cath lab doing a multivessel PCI procedure on an awake patient. It's not good for the patient, and it's probably not economically good for your cath lab. And there are operator and cath team considerations. If you do PCI at a hospital that does 100 PCIs a year and a hospital that does 1,000 PCIs a year, you can't take the patient like the one I just showed you to the 100 PCI hospital and do that revascularization. It's not fair to your cath lab team. Multivessel PCI and complex PCI is a team sport, not an individual sport. If the air tanks for your rotablator double as a lead rack in your cath lab, you probably shouldn't be doing left main atherectomy in that cath lab. If the last time an unprotected left main was done in that cath lab was when the Saints won the Super Bowl, and I'm a Saints fan, you shouldn't be doing unprotected left main in there. And if there's no MCS, if that cath lab doesn't have Impella, even if you don't plan to use it at the onset, you don't have a bailout if something goes the wrong way. So that's probably not the cath lab to be doing that procedure. And you have to train up your team, get the necessary tools. So I've shown you data, very compelling data, that complete revascularization leads to improved outcomes. I've shown you provocative data that one-stage revascularization leads to better outcomes than multi-stage revascularization, and that in fact multi-stage revascularization may not be as benign as we thought it was 10, 15 years ago. So as an interventional cardiologist, if your mission is complete revascularization, learn the tools, develop the skills, and build the team to help your patients. Thank you.
You've been watching a protected PCI.com video.